All right, thanks very much. It's a real pleasure to be here, especially when you guys are honoring Craig and Andy, who I have a lot of history with. I'm going to talk about a very challenging topic, and obviously I can't delve too deep into every aspect of this, and you're going to hear many talks later today and some tomorrow that'll go into greater detail. And this is just Fred Hutch on a typical day in Seattle, if you believe that. So what are the approaches here? So I think there have been four major advances in the treatment of lymphomas. First are antibodies, and I'll go through issues targeting antibodies that actually target the tumor. There have been antibodies now that modify the immune responses, and these are heralded by the checkpoint inhibitors. There have been T-cell engaging bispecific antibodies, which is another class, and then lastly, CAR-T cells. And I'm going to talk about our data with CAR-T cells and highlight a few of these other areas. And again, you'll hear more about them as the day goes through. So what about antibodies? Rituximab represented, I think, the first major paradigm shift in the treatment of lymphomas. And Rituximab clearly represented the first successful antibody in lymphoma. This is an example from a paper in the New England Journal that I was asked to do, but just to highlight how antibodies work. And remember, the antibodies work by either direct effects, inducing apoptosis directly in the cells, or by immune effects, either by inducing ADCC through effector cells or through complement. And CD20 is an ideal molecule that's held tightly in the cell surface. It stays on the cell surface for the most part, and anti-CD20 antibodies have had activities. Now, surprisingly, they didn't have very much activity. As a single agent, they were quite disappointing in this 30 to 50% response rate. But when you combined rituximab with CHOP chemotherapy, you now got survival advantages. And so this was the landmark study from the GILA group looking at elderly patients with lymphoma who were treated with R-CHOP versus CHOP. And surprisingly, a 10 to 20% increase in survival was seen. And this has been seen throughout most studies. And then this became essentially known as vitamin R in the realm of treating patients with any CD20 positive malignancy. Now, this has also been used in maintenance, and this is just a study from the PRIMA group, which took patients who had been treated to at least a partial remission with R chemotherapy, and then they randomized them to either receive rituximab maintenance or observation, and there was an improvement in progression-free survival that was fairly significant. There was no improvement in overall survival, so this remains somewhat controversial, but is very, very widely used in many patients. So rituximab became very widely used as modest single-agent activity. And the reason it was widely used was because it had low infusion-related toxicity, a relatively low rate of long-term complications, immunodeficiency and B-cell depletion can be seen. But because of this, was able to be combined in full dose with standard chemotherapy regimen without any dose compromise. And R chemo was better than chemo in most histologies. And then maintenance seemed to work. And because of this, rituximab based chemotherapy has been widely adopted as frontline therapy in nearly every CD20 positive malignancy. And it's also widely used in salvage chemotherapy without obvious proof often in that setting. So is there a next generation rituximab? So everybody wants to make a better rituximab, including Genentech and Roche, as rituximab is coming off of patent. And so there's been extensive effort trying to make a better antibody. One antibody, ofatumumab, has now been approved. It's a human anti-CD20 antibody with increased complement. It binds slightly different to the CD20 molecule and has been approved in fludarabine refractory and now relapsed CLL, but surprisingly has never actually beaten rituximab in any head-to-head comparison. In fact, there have been two studies. I was the PI of a study just that looked at ofatumumab versus rituximab in rituximab-sensitive relapsed follicular lymphoma that completely failed, and so absolutely no benefit. And it failed in also rituximab refractory NHL. So I don't think ofatumumab is the next rituximab, although it clearly does decrease sometimes the immune responses to rituximab. Well, what about obinutuzumab? This was widely heralded as the next antibody. It's a glyco-engineered antibody, has increased ADCC. It's type 2, and it has greater direct effects inducing apoptosis. but it also has greater infusion reactions. It's now beaten rituximab in a study for CLL. Brentuximab plus chlorambucil beat rituximab plus chlorambucil, although they did use a higher dose of obinutuzumab, which makes the study somewhat difficult to interpret. In actually comparison to rituximab in indolent lymphoma, it was exactly the same. But in a recent study just published by Lori Sen in Lancet Oncology, bendamustine plus obinutuzumab in rituximab refractory patients was better than bendamustine alone. And the curves are actually shown here. These are the progression-free survival curves showing the combination was better than bendamustine alone. But if you look at this really closely, it turns out that all of the benefit appears to be during the maintenance course, which makes you wonder whether rituximab refractory is really truly rituximab refractory, and if this control group had gotten an anti-CD20 antibody, it probably would have been similar. So I actually discount this study immensely, but this was enough to get brentuximab approved for lymphoma. There's also going to be, I think, a plenary talk at ASH this year showing obinutuzumab chemotherapy versus R chemotherapy in indolent lymphoma. We've heard that that was a positive study in a press release. But unfortunately, the obinutuzumab plus rituximab study for aggressive lymphoma completely failed. And so R-CHOP is now, again, the standard for aggressive lymphomas. So there's a lot of antibodies in development. These are just a list of some of the ones that are being looked at. Unfortunately, this is an incredibly difficult market to penetrate and to displace rituximab from. And good luck if you're trying to get an antibody approved in this situation. All right, that's all I'm really going to say about naked antibodies. The drug conjugated antibodies obviously are a slightly different mechanism of action. They're actually bringing a toxin or a payload to the cell, and Brentuximab Vedotin is the first approved ADC for lymphoma. This is an anti-CD30 antibody, and it brings a tubulin-targeted agent or a statin, MMAE, and this is toxic to the cell. This was studied in Hodgkin's lymphoma, as you heard earlier, and they took heavily pretreated patients who had failed prior transplant, and this is a very impressive waterfall plot and was enough to get this drug approved as a single agent, again showing progression-free survival curves. This was also then taken as a proof of concept study into a randomized study post-auto transplant. This is a placebo-controlled study, and you can see this study was also positive in terms of progression-free survival, and Craig was obviously instrumental in this study published in the Lancet. So this is an example of ADCs that are clearly a new wave. There are several other antibodies other than brentuximab. Polatuzumab, targeting CD19B, is also likely to be approved in the future. And as you can see, there are a number of antibodies directed against targeted antigens. Of course, these antigens have to internalize, so CD20 is not a great target for a ADC, although it may internalize slowly enough that it still could work. So I think these are likely a wave of the future, and that they will eventually replace or substitute for some of the agents in specific chemotherapy regimens as a more targeted approach to get the drug to the tumor in a greater fashion than to the normal cells. Well, what about RIT? You saw that one of the cases was treated with ibrutinib Tiuxetan or Zevalin, and there was a lot of fanfare about radioimmunotherapy. This was the FIT trial, where they took patients who had previously been treated with low-grade lymphoma, randomized them to no further treatment or consolidated radioimmunotherapy, and this showed a big benefit for the radioimmunotherapy. Problem was this was pre-rituximab. There was no rituximab maintenance, and so despite this being enough to get the drug approved, it was not widely used. In the SWOG group, we did a study with SWOG 016, which was randomized patients initially to CHOP plus rituximab, or CHOP plus I-131 tosatumumab, or Bexar, and this was published by Ali Press. And the data from this showed that there was slight benefit in progression-free survival to CHOP plus radioimmunotherapy versus CHOP plus rituximab, albeit there was no maintenance therapy given. in this setting. But the survival actually came out exactly the opposite. CHOP-R was slightly better than CHOP-RIT. And I think the only point I would make here is look how good this survival is. This is 80 to 90% at close to 10 years. And if you think back to the bendamustine and Rituxan studies that were published from Dr. Rummel, then this really beats that heads down. And so I'm extremely concerned about some of the bendamustine studies, and I'm still in the CHOP rituximab type camp for aggressive follicular lymphomas. Now, what about, so I think unfortunately radioimmunotherapy is essentially dead. There's a lot of issues with toxicity. It's an incredibly active therapy, but until we learn how to use it better, it's been a very difficult market. I'm just going to say a couple words about BiTE therapy. These are T-cell engaging bispecific antibodies, and Brentuximab is the first approved construct. So this is taking essentially the binding domain of a CD19 antibody and a CD3 antibody, hooking them up essentially back to back as a T-cell engager. This then links up a random cytotoxic T-cell that expresses CD3. Now with the tumor cell expressing CD19, this engages the receptors and essentially forms a synapse, and the T-cell can now essentially non-specifically, at least in terms of the T-cell receptor, is able to kill the leukemia cell. And this was sufficient to be approved for adult ALL, and it's a somewhat complicated treatment in that it's infusional, requires 3 weeks of infusional treatment, and at least in Europe required hospitalization in the initial studies. But you can see there clearly are major responses. Toxicity was fairly significant, and there is an issue with neurotoxicity that's similar to what is being seen in CAR-T cells. This was sufficient to get the drug approved in ALL, and there's now increasing activity in other lymphomas. This was a recent paper in Blood from this year showing 21 evaluable patients treated with a stepwise escalation of Brentuximab at between 9, 28, and then 112 micrograms per day weekly for the 3 weeks. The response rate was 43% with 18% CR, and you can see the toxicity was largely neurologic with tremor as well as fever, fatigue, and edema. Neurologic toxicity included encephalopathy and aphasia, and these were generally reversible. But again, this is an approach where this essentially non-specific engagement of T cells might be able to provide anti-tumor activity. Now, can't have an immune talk without at least mentioning the checkpoint inhibitors, and you'll hear again more about this. This has largely been driven by the observation that anti-PD-1 antibodies are remarkably effective in highly mutated tumors, and essentially the anti-PD-1 antibodies block this PD-1, PD-L1 axis, which causes a negative regulation to the T cell. And by blocking that interaction, you essentially are activating T cells that are trying to respond to the tumor. And this can also be done through the CTLA-4 axis. And so these antibodies have been used in Hodgkin lymphoma and shown a remarkable effect. And this is responsible for approval in the setting. And you can see high waterfall plot, high degree of anti-tumor activity in patients with Hodgkin's lymphoma given a PD-1 antibody. Well, this has largely been taken into lymphomas. You saw a little bit of data earlier, and you'll hear more about this. But responses in other lymphomas has clearly not been as high as it has been in Hodgkin's, but there is some activity in follicular lymphoma and large cell lymphoma, and I think this does represent a wave of the future. Now I'm going to spend the last few minutes on CAR-T cells. There are many ways of modifying T cells. One is by transferring in T cells to the T cell receptor, and this can be done against specific antigens, but it still relies on recognition through HLA of peptides. And obviously the more active way of doing this is the CAR-T cell receptor. This has been pioneered here and at other centers, and you'll hear much more about this later. Really, the major breakthrough in this was to use the second generation CARs, which are shown here with the CD28 or 41BB as a co-stimulatory domain to make the CARs signal better. In Seattle, we have used CAR T cells made from distinct T cell subsets because those subsets differ in potency. And this was an example from Stan Riddell's lab where CAR T cells are manufactured from CD8 central memory cells, and they were more potent than other populations. And so if you then give a mixture of CD4 and CD8 cells in a one-to-one mixture, then you also had synergistic activity. So our studies are been focusing on engineering selected T cell subsets rather than just what you get from the patient's blood. So this is the Hutch Protocol 2639, which we've now treated 150 patients with B-cell malignancies with CAR T cells. We're using a lentiviral vector using the 41BB co-stimulatory domain. Patients have a leukapheresis. We select CD4, CD8 cells, make independent CAR T cells, and give them back after lymphodepleting chemotherapy. This takes about 14 days to make the CAR T cells, and we have no criteria on absolute lymphocyte count, a test expansion, circulating tumor, or prior transplants. So we've now treated people post-haplo, post-cord bloods, post multiple other types of allogeneic stem cell transplants as well. And I'll just show you a little bit of data on non-Hodgkin's lymphoma. We've treated 41 patients, variety of histologies, a median of 4 prior regimens, and about half have failed prior transplants. We started off with a cyclophosphamide lymphodepletion, essentially to make space for the CAR T cells, and we added fludarabine to that, and I'll show you why. And we've been able to make CAR T cells in virtually all of these patients. Here's one of the examples of one of our first patients. This patient had absolutely refractory disease and had, with a follicular grade 3 lymphoma, had no response to an auto transplant, progressed within 3 months, and then had no response to salvage high-dose cyclophosphamide etoposide lymphodepletion. And day 28 after CAR T cells had a remarkable response with almost no toxicity and with really only fever. And it told me his lymph nodes felt like ice cubes melting in his neck, and it was really quite an amazing thing. Now, unfortunately, about 2 months later, his disease started to progress. And what we found out was that he'd made an immune response against the CAR T cell. And so he had developed a CD8 T cell that killed his CAR T cells. And so this turned out to be a big problem in the patients treated with cyclophosphamide-only lymphodepletion. And so could we intensify the lymphodepletion and try to decrease this immune response? And it turns out if you give Cytoxan and fludarabine, so 3 doses of fludarabine added to high-dose cyclophosphamide, you can now get much greater CAR T cell expansion and persistence. So shown in red here is the CD4 on the left side and CD8 CAR T cell persistence, and these are log numbers here, so you can see much greater CAR T cell expansion following Cy/Flu lymphodepletion. And in fact, for the first time, we've now been able to show that there's a dose-related CAR T cell expansion based on how many CAR T cells you give. Again, these are defined CAR T cells of CD4, CD8 composition. So if you give higher numbers of T cells, you get a higher expansion. And the Cy/Flu lymphodepletion now increases the expansion and persistence, as you can see in these two curves. Red is the Cy/Flu, and log numbers are going this way in terms of peak CAR T cell expansion. This is also somewhat correlated with the amount of target you have around. So if you have a lot of tumor in the bone marrow, then you can get a greater levels of expansion. So when you actually measure patients' blood after they've had lymphodepletion, you find higher levels of endogenous IL-7 and IL-15, which is then contributing to the CAR T cell expansion, and then this leads to greater CAR T cell expansion and overall persistence, and that translates into better responses. So now we've been able to prove that you get a correlation of tumor response with CAR T cell expansion in the blood, and you can show this by either the area under the curve or by the peak levels. And this then translates into higher CR rates. So if you give Cy/Flu versus no Cy/Flu, you can see the CR rate has gone up to about 50% in the Cy/Flu groups. And also, when you get the dose right, you can improve the response rate even further. So adding fludarabine was critically important in our lymphoma categories. Overall, we've seen anti-tumor activity in many histologies. You can see here, this is just the patients that treated with Cy/Flu. This is an example of a pleomorphic mantle cell lymphoma that failed an allo transplant, remains in complete remission now out about a year after CAR-T cells. And so this gentleman was in really tough shape due to local obstruction from this mass. This is the patients receiving Cy/Flu in dose level 2. Survival is obviously good if you have a CR. It's really important to get a CR with this. If you don't get a CR, then it's not really, it doesn't really count. And so it's really important that we can improve technology to improve complete remissions. So what about toxicity? This is looking now just at the first 32 patients. Cytokine release syndrome is the major toxicity. This is mild to moderate in most of the patients, severe only in 4 patients, and this was dose-related and mostly seen after too high a dose of CAR-T cells. It was actually very interesting. We dose escalated all the way up to the highest dose level without fludarabine, so saw no toxicity whatsoever. Added fludarabine and had 2 deaths at 2 by 10 to the 7 cells, had to dose de-escalate all the way back down to 2 by 10 to the 5, and ended up at 2 by 10 to the 6. So if you add fludarabine, you'll get greater CAR-T cell expansion, and that can translate into greater toxicity. So it's a direct relationship. The fludarabine isn't causing toxicity, it's causing greater expansion of CAR-T cells. And the major toxicities are either severe CRS or this neurotoxicity, which was somewhat unexplained. The patients get an encephalopathy, or dysphagia or tremor, and this is generally very mild and reverses dramatically within a few days, but can be very severe. This severe toxicity is directly correlated with CAR-T cell expansion, and you can measure this by serum markers. So for example, you can measure the CD4, CD8 levels or area under the curve, and you can see patients who have higher toxicity have higher expansion. You can also look at markers such as IL-6, interferon gamma, ferritin, or CRP. These peak levels correlate with toxicity. But that doesn't really help you too much because that's after everything has really been done, and you can see neurotoxicity is a similar story. But you can actually look one day after the CAR-T cells are infused, and you can get a hint at who's going to do badly. And so we can now predict who's going to get severe cytokine release syndrome or neurotoxicity based on cytokines one day after the CAR-T cells are infused. So it's 24 hours after, and so that way you can know at least who you're going to be more worried about and potentially intervene with tocilizumab or with dexamethasone. So when we look at all of our patients now across ALL or NHL, you can see by using risk-adapted cell dosing and Cy/Flu, the toxicity is quite respectable. In lymphoma, again, relatively rare to get severe neurotoxicity, and you can also see in CLL it's similar. We're able to do this as an outpatient in most patients. This is the median days in the hospital, around 5 to 6 days. So most of this is done as an outpatient, and you can see some patients don't require any hospitalization. So I'm going to conclude there on our rapid tour of immunotherapy. I think monoclonal antibodies has made immunotherapy the new standard for lymphoma therapy. The search for better Rituximab is continuing. I wouldn't hold your breath. Radioimmunotherapy, while active, is used infrequently due to complexity and long-term risks, such as MDS and leukemia. The antibody drug conjugates are beginning to gain a foothold, and I think they're going to be the wave of the future, at least in terms of probably substituting for many parts of chemotherapy regimen. Checkpoint inhibitors represent a major advance, although it's somewhat non-specific. I think as we learn more about this will also be a very important moving forward. It can be combined with nearly all other treatments. The BiTEs are also likely to advance further once new constructs come into the field. Right now, having to do continuous infusion for weeks on end is pretty difficult, but there are some more stable constructs that can be given by essentially like rituximab. I think CAR T cells represent a major breakthrough with curative potential for ALL, CLL, and lymphoma, and combinations with checkpoint inhibitor antibodies are also ongoing, and you're going to hear a lot more about this as we go through the day. But we need a better understanding of the mechanisms of toxicity and management. And I'll stop there with thanks to many of my contributors. Thanks very much.